Good morning, and welcome to What Boomers Want as it applies to health and healthcare. We're going to get started in a few minutes, and if I could just ask everyone to turn off their electronic phones, cell phones, Blackberries, because it will interfere with the recording. I appreciate that. And if you could just settle in, this is going to be a very exciting, especially the speakers. Very exciting conversation about boomers. And I just wanted to start the conversation by saying we're going to change up the format a little bit today. We decided amongst ourselves that the very best way of presenting this topic is brief comments. I'll do the intro, and then I will introduce our panelists, and they will give opening remarks very briefly, and ultimately do what Aspen does best, which is engage in the audience. The interaction with the audience is probably the most exciting part. So with that, I'd like to also say we'd like to take a poll. If you've been born or were born between 46 and 64, would you raise your hands? We'd like to see. Very good. That's about half. About half. We like to know to whom we are speaking. Okay, to set the stage, I'd like to talk about the 75 million baby boomers who are growing up, not growing older. They're demanding healthier and more active retirement years, and we learned yesterday from John Zogby that that is called encore life, not retirement life. So, and in this process, they're changing the face of medicine. And the change, the emphasis from life span to health span. So when it comes to health, boomers want what every other generation wanted. They want nearby doctors and medical services. They want assistance to allow them to be independent for as long as they can possibly be. And they want the opportunity to continue to contribute to the country and to society. So every age group has its own generational marker. And what we're going to be discussing today is what health issues make the boomers distinctive and why, and what are the long-term implications. So with that, I'm going to turn my attention to my panel. I'm going to introduce them, and then they are going to have an opportunity to say a few words about what they think the demands of the boomer are. First, Dr. Ronald Dozoretz. He's the founder and chair of FHC Healthcare Systems, and he is currently chairman of ValueOptions, a subsidiary of FHC. He regularly participates in setting healthcare industry standards and has been recruited by health policymakers in the White House to assist in the development of national healthcare policy. Dr. Dozoretz is a founding contributor of the Dozoretz National Institute for Minorities and Applied Sciences at Norfolk State University. He's also an assistant professor of psychiatry at Eastern Virginia Medical School and an appointed fellow at the Center for Public Leadership at the John F. Kennedy School of Government at Harvard. Martin Payson, to his right and your left, is currently a managing partner of Karl Marx Healthcare Partners and chairman of Maimonides Medical Center and Nassau Healthcare Corporation. He was formerly vice chair of Time Warner and is serving on the board of governors of Howard University Hospitals. And then our last panelist is Robert Blancato, who's the president of Matz, Blancato and Associate, a firm integrating public relations, government affairs, and advocacy. Previously, he spent 16 years as the chief of staff of a member of Congress, 11 years as the staff director on the House Select Committee on Aging. In 1995, he served as the executive director of the White House Conference on Aging, and he has also served on the 2004 Policy Committee for the 2005 White House Conference on Aging. And now, Dr. Dozoretz, over to you.
Thank you very much. In preparing for this, I did what it was easiest for me and most experienced, and that is I polled all my friends and every dinner party we had and every gathering. I would ask the group who were seated there this exact question. And it's an interesting, you really get a variety of answers from one of my friends saying yesterday, I want immortality to more realistic aspects of it. One of the best studies I found was Mark Penn did a study recently, just a few months ago, on baby boomers, and he found some fascinating information, which I thought might stimulate a discussion, because as we discussed, I think the best way to deal with this is to have is to really have an open dialogue on this, because there is not a huge amount written, and each one of us approaches baby boomer time differently, and a lot of it depends upon our economic status, to be frank, and who's paying for our health care. If the government's paying for it, there's one group, and if the rest of us are paying for it or involved in it deeply, obviously there's many other ideas that one would want. This group is clearly approaching this time with more information, more options, more choices than anyone else. And one of the biggest things that I have noticed, when I was younger, my mother and family would go to the physician, and the physician would state what happened and what didn't happen, and by and large the family pretty much agreed and went along with the physician, who was a key member of the community. That has really changed dramatically, because all of us now have broad access to huge amounts of information, and with that information, we no longer, the group says, I'm going to go here for a knee, or here for or a heart, or here. We tend to look around the universe, which we have access to, and we tend to pick what we want and who we want to deal with. There's 4 or 5 things that Mark did bring out, which I think hopefully will be interesting to you. One is that this age group clearly works longer, and he describes them as the working retired, that Americans tend to like work, and that nobody stops working, or not no one, but people tend to not stop working at 65. They tend to work, and that has huge implications, as you can imagine, because the younger group gets promoted at a different level. We tend to, there's a huge movement with older fathers, and people who are 40, 50, 60, having children, and that has massive implications on schools and other aspects of their lives. And it tends to keep them younger, like myself. I have a 14-year-old boy who's in the audience, and my 10-year-old daughter who's at camp in Maine. This group tends to do more surgery. They tend to pay for surgery, no matter what economic level of it. People tend to have a lot of elective surgery. Hearing is a massive problem. We used to talk about eye problems for this group, but hearing is now been hugely affected and has its implications. And the last of this is this issue which we've all read about, which is commuting, which is a massive. The number of people commuting from point A to point B to work has dramatically increased. And then the last point I'll make is in his study, he found that this group depended more on the health care programs of the work or their employers rather than getting a new health care program. That if you ask them their 3 top issues, health care insurance was not one of them, but what was one of them was clearly having enough money for retirement and a healthy life. And I think some of these things might be interesting for discussion later.
Good morning. I don't want to be redundant, so I'll just reaffirm what I've heard, but I think there are a few other aspects to it. One is that they are worried, though, somewhat about their coverage, because about a fifth of baby boomers have no coverage, and they're worried because of the employer plans of loss of coverage at this stage in life, particularly with the recession. I'm from New York, and there's a well-known retailer who advertises our educated consumer is our best customer. And essentially, at Cy Sims, and essentially I think that's true of the baby boomers. They are an educated consumer. At Maimonides Medical Center, we deal with the extremes of age, the very young and the very old. Our most frequent contact with the boomers really come in as the sandwich generation, because they're the parents of the young and the children of the very old. And so they come in, okay, protecting both ends of it. One of the ways we have to respond is both, not just this is the way it is. We have to make sure that there's respect. One of the problems in the medical system has been doctors have been king, not only in the wise man, but also there's been a sense of arrogance over the years of how people are treated, and they won't accept it. And they rightly won't accept it. So at Maimonides, one of the things we have is we have a code of respect among the doctors so that they know how to treat each other and they know how to treat the patients. So essentially you have a generation that knows the technology. They come in well-read. They demand questions. You have to be respectful. But at the same time, you have to make certain, essentially, that there are lines you draw where they have to learn a sense of diplomacy. Some of them have it and some of them don't. In connection with my readings on the boomer generation, the insurance industry is not concerned but is looking forward that they won't accept the old forms of insurance. They will want more options. They want to see that they get the best value for their policy. They will look into it to the extent that they have a option. And I think the final thing is, at this stage, is they want to stay, and properly so, they want to stay out of the hospital as they age, and they want to be able to see that their parents stay out of the hospital, and they want to age at home and be healthy, all of which are positive. So from a hospital point of view, you're really dealing with a breed of people, okay, more of sort of a peer group than a subjective group. The last thing really is, because of their numbers, and as they age, it's going to have a huge impact on all of our institutions, but particularly medical centers. They're going to be under pressure of numbers because we all know, no matter how healthy we are, as we age, we have more and more need for the service. So how the hospitals, not today, but as we go along in the next 10 years or so, will be able to handle their demand. Those are sort of my opening comments.
Bob?
Thank you, Franmarie. So we talk about baby boomers, the most overanalyzed and least understood generation in America. We've had 2 White House conferences on aging dedicated to issues around boomers, and we still are struggling to come up with answers. So one of the answers to what boomers want in healthcare may be who knows. Depends on which boomer you're talking about, because you have a 20-year cohort to deal with. They're going to want healthcare that is, of course, affordable and convenient. They're very much on anti-waste. They want to see costs lowered. They want consumer direction. They want patient-centered care. They want coordinated care. And they want a new focus on communication between the healthcare professional and themselves. They want wider choices, especially as they age. They want more focus on prevention. They would like to see a Medicare program become a wellness program to some extent. But at the same time, they have a rising rate of obesity, which must be addressed in that generation. They want long-term care that will focus on home and community-based care instead of institutional care. In year 2030, 6 out of every 10 boomers will have one chronic disease or more. They want doctors and others who are trained in geriatric medicine, which is something we're still struggling with as a nation. They will demand better cultural competency in who and how healthcare is delivered, and they want to see a reduction in healthcare disparities. They want to see an expansion of complementary and alternative medicine. They want to learn more online about healthcare. They want to look at other options. Wireless solutions, digitally stored medical records. They'll take convenience to some extent over privacy. They want more answers. They're less accepting of things than the previous generation. They want things that are going to help them avoid dependence. They're going to want to see greater support for family caregivers. Huge issue in this country that doesn't get enough attention, and there isn't certainly not enough policy to help family caregivers. They will support, as they have in the past, research into illnesses and diseases such as Alzheimer's and cancer. And then the last point I'll make, since Franmarie opened with how many of you are boomers, and about half the room raised their hand, how many of you are in denial of aging? Raise your hand. That's the more honest question to ask, because that is clearly what boomers want, to delay aging. Thank you.
Thank you. Okay, now I'm going to open it up to the floor. Are there any first questions? And if not, I will take the first question, and you can start formulating yours. All of those comments were really quite succinct, and I totally agree with all of them. What are the implications for the healthcare reform if the boomers are so adamant about things that are not being addressed in the healthcare reform that we see today? Any? Would you like to take that?
Well, I think the healthcare reform is so complicated, okay, that they don't have a particular effect. I mean, President Obama, I guess he's too young to be a boomer, but I think he understands this generation. I think he thinks like this generation, and that so the influence I think that they will are having is through his thinking and that around his people, many of whom are boomers. And when you talk about President Obama, efficiency, paying for the system out of technology, paying out of not waste, I think it falls in line with what the boomer generation is about, as I understand the generation.
Ron?
Well, I have strong feelings about the healthcare reform package and what should or should not occur or have occurred, because I've been in this healthcare business all of my life, and 35 years of profession, and the one thing I've learned through the years is that you cannot take this complex system and just, quote, reform it. It is not going to happen. And no matter who in Washington thinks that it is going to happen, it is by nature going to be a problem. So what people like myself who have been in the business have said and thought, including an editorial that Senator Tom Daschle wrote, is this is a process. It is not an event. And the process of it has got to occur over time. And that what I would have recommended to the administration is that they enhance Medicaid for the poor, increase the lower level of eligibility for people and bring that group in because it's already existing. Enhance Medicare and bring the elderly in, and that takes care of a large group of people. And then use the existing system, which is very complex, very much there. You may or you may not save money immediately, but what I feel, and many people a lot smarter than I am, is that nobody really knows who these people are or what they want. And what I thought they needed to do was to find out who they are, where they live, and what do they want. And it's pretty basic when you run a business like I do, where we manage 23 million people in America in an insurance plan. I'm not unsophisticated with large groups. And what I thought they should do is find out who they are. Let the existing system register them, put their names, address, social security number, and find out what are their needs and what are their ages, and what are their goals, what do they want. And then with that, move to another step. But this idea of doing a government plan, I think is way overreaching. And the last thing this country needs now, when you have the DOD as a health care plan, you have the VA as a health care plan, you have Medicaid, and you have Medicare. We don't need another plan right now that no one knows who it'll cover or what it'll cover.
Thank you, Ron. Bob?
A couple things come to mind. I mean, again, nobody has the crystal ball to know what the outcome is going to be on this health care plan. Anybody who tries to, I think, is not being totally accurate. But remembering that in less than 2 years, the first wave of boomers become eligible for Medicare, since they'll be turning 65. Some of the reforms that are being proposed in Medicare could be construed as being boomer sort of oriented, such as an emphasis on care coordination, an emphasis on quality versus quantity of services and things of that nature. If Senator Kennedy's Class Act dealing with services, long-term services and supports for older people and disabled people is to be retained in the final package, that would be viewed as an element of importance to boomers. And I think that depending, again, on what happens, some things may emerge that could be construed as being in the direction of where boomers want to go. But I think Ron is absolutely right. I mean, it's a massive undertaking that really, our history with policy is we do better work incrementally than we do when we try to take a whole thing. I used to work for a guy named Claude Pepper years ago. Some of you may remember him.
Oh, yes.
He wanted to take long-term care on right after the debacle of the catastrophic health care bill. When they passed the bill and repealed it a year later, he was right then, but they weren't ready. And had they just taken that first step, by now we would have something resembling a long-term care system.
Thank you, Bob. All right, we're now going to turn it over to the audience. Sir?
So take it out past health reform and let's go out to 2030. We're there. 6 out of 10 boomers have one condition at least, if not more. So thinking today, how would you redesign your institutions, your hospital, insurance company? What are the products you would offer? Try to get specific. What are the products you might offer? What are the service lines? What's the staffing complement you might want to have? How would you redesign yourself to meet the needs?
I'll take a.
You have 22 years. Go.
I'm a lay leader. I'm not a professional, but I've been exposed to medical centers in New Orleans, Washington, and Brooklyn, and Nassau. You can't take it out to 2030 from an administrative board point of view. You're struggling. Your margins are so slight to the extent that you have margins. So if you plan, you're planning in a 5 to 10 year framework. I think that's, and if you're doing that, you're probably ahead of the curve as far as you can be. For example, you don't have capital at the hospital level. I'm not talking about the for-profits, because I'm talking about the urban medical centers, or it could be the rural ones, which I'm not familiar with, but those who treat the masses and people, their margins are virtually nil. So one of the things I have not heard about in health reform is how are we going to get capital to do the things that will be required, okay, for this generation and the following generation, and the mass of people that we have to treat today. The other thing we haven't heard, we talk about baby boomers, but there are also a lot of immigrants who have different characteristics than the general characteristics we're talking about of those who essentially were born post-World War II in the United States. And they have different needs and different cultural needs. So the concept, from my point of view, of thinking about 2030 is, it's just inconceivable at the hospital level that we can be planning to do it.
Bob? Ron?
Ron?
This is
defer
the
to my
best
colleague. I defer to my
One thing I can tell you that if you don't do, the system will never survive, and that's we have to have a common database. Now, what does that mean? That literally means that no matter where you go or who you see for care, you have one chart. You have one number, one chart, one system, and until we reach that, you're going to have costs all over the place. And what I have thought that they needed to do was to do a electronic medical record. Now, this is not exactly brain surgery here. I mean, we did HIPAA. We've managed to do things that insurance companies and maybe even individuals don't like. But in a sense, if the government is going to pay for it, that's life. And every insurance company and everyone who accepts government money has to have a common database. Now, what does that basically mean? This is not radical. It's basically the same, your name at a place, your address at a place, your diagnosis at a place, your number at another place, so that the data can be gathered about illnesses and why you went and what are the costs and what are the treatment plans. And until we do that, you can imagine, take colon cancer. If we had the database of the 76 million boomers or the 50 million people insured, can you imagine what that would mean if we were able to click and say colon cancer and find out every person and every area in the country that treats colon cancer? And then we could look into that and find out who treated them, what were the treatments, what were the costs, what were the successes, and what were the failures. And until we get more data and more information, it's going to be very hard to predict because we're all over the place. We don't have data. And one of the problems with the program in Massachusetts, everyone wanted fee for service. We happen to be in Massachusetts. We happen to do the mental health for the Medicaid there for 15 years, so we're very deeply involved in that state. And if you've read, you see what's happened. Their costs have now gone through the roof because the individuals wanting the care, keep wanting more, which is natural, and the people delivering the care want to give more, and that's natural because that's the incentive system that we live with. But that has to change. It has to change.
Bob?
I'll since I'm not in that field myself, but you picked 2030 as a fabulous year because that's really when the age boom explodes and hits its major peak. But it would seem to me that what you're looking to try to get to by that point is a greater emphasis with dollars on things like prevention and wellness and provide greater Medicare coverage for preventative benefits. I mean, we've increased them quite a bit over the past few years from where they used to be. Need to do more of that. But then you need to fund other services that could keep people in their homes and their communities more. Respite care, for example, which is just emerging now as an area of possible focus. But I think at the same time, I think it's a matter of a closer consultation with the individual and what they want in terms of care. And I think we could spend more time focusing on patient care.
Thank you, Bob. I'm going to go over to this side of the room. Dan?
Years ago, there was a movie called They Were Expendable. It was a war movie.
P.T. Boats.
Yes, that's right. And one of the things that strikes me is as boomers age, and I happen to be in the post-boomer world, where I know I can't, that doesn't look possible. And this conflict between cost containment and outcomes versus the American culture that people want to have any kind of treatment that's going to keep them alive. And I think one of the things that I think older boomers worry about and people of my age worry about is we're going to move into a medical system where we really become part of a collective statistic. And it will have an impact on treatment regimes. And people will not be given the extraordinary services that almost everybody needs as they get older. And we heard yesterday from Billy Tozan, who went through this cancer situation. He told me that the treatment regime that he himself picked for himself was regimes that basically the insurance companies wouldn't pay for, but he pushed it and he took care of himself. And then and so I just ask this question is that this conflict between the American desire, the cultural desire to preserve all of our lives at any cost, and we know that there are these decisions being made by insurance companies in this country now as well, but with a healthcare regime that kind of gives you some sort of striking resemblance to what's happening in other countries where they do not individualize their services at all. I just thought it seemed to comment on that. That is, when we get old, are we just going to be left at some age, it's not worth the cost of the treatment to you?
Well,
Mark?
The area that our hospital, we are a 700-bed tertiary hospital located in Borough Park, Brooklyn, which deal with the ultra-Orthodox and Hasidic communities who demand, forget the baby boomers, okay, treatment and surgery for people into their 90s. So I know, okay, as a hospital, we have to deal with those issues today. And to do heart surgery, which we do from time to time, probably a few other hospitals do, on a person 90 years, and sometimes it's successful, so you get another year or two. and sometimes it's not successful. If it's not successful, the consequences are either death or worse, disability. So we deal with that day to day. I think from the hospital level, I'm not a policymaker, and that I believe what Ron said before, the incremental nature of what's going to happen is the reality. And I think the reality is that over time, the financial pressures, which are real, will bring down the choices, and people will come to accept that there will be limited choices. But at the same time, at the hospital level, okay, well, not only all the health things you talk about, there are so many things we can do to bring about efficiencies, to treat the patient better, more compassionately. Compassion. Okay, we have programs for home health care. I mean, we had the program yesterday on the aged. I don't want to repeat that. But there's so much you can do, and the system doesn't reimburse us for it. We have the highest Medicare case mix index in the city of New York because of the aged population that we deal with. Earlier this year, we found that that index dropped significantly, and of course it has dramatic economic impacts on us. And so we tried to study it, and yet the patients coming in were the same patients. What did we learn? We learned that about last fall, we introduced a rapid response team. We organized rapid response teams to be able to once, and then most of the people we're talking about elderly, in the hospital, and that they're in trouble. Instead of the normal chain of command, you pick up one number and a team comes in. It dramatically reduced the amount of incubation we have to do and all the procedures we do. We got it wrong. So what was the effect? Okay. We suffered economically for doing a better job. So this is an example of the change the system has to help at the hospital level to reimburse us for doing a good job. We were being punished because we were treating the patients, and our intubation dropped a lot. So what I'm really saying, it's an incremental form, but the idea of payment and reimbursement for doing a better job, for doing the job of following the patient at home. We do not get paid very much for following the patient home. We need grants for that. So I think this is all. And is it going to happen with the flow of one pen? I doubt it. I believe that is exactly right. But I think between now and these times, a lot will change, including the culture.
Bob?
You know, Dan, putting on your political hat, every time the topic of cost containment comes up, the first thing that comes out of it is care containment follows, and it concerns people. I mean, what's the great, one of the great buzzwords that's being thrown around now? Rationing, you know, of healthcare, because there's proposals about how to trim Medicare's costs by a significant amount of money. So it's a tough conversation, but it's one that's going to happen, and it's one that's probably going to happen constantly over the coming years. But whoever takes it on and takes the lead is going to probably incur some political hazardry from doing it.
Ron?
I'll give you two personal stories. One is when my mother was post-op, and she went into a coma. At several weeks after being in a coma, they wanted to do dialysis on her, and it was obvious to myself and other people that she was not going to live, and myself and my sisters decided it was not a rational thing to do, and we didn't. And we had the same thing with my father, who was well in his 80s, very healthy until he got lung cancer. And we decided also to not resuscitate. Now, those were, and still are, frankly, when one talks about them, they're emotional things which one lives with their whole life because you make those decisions. I'm not sure if they're right decisions or they're wrong decisions, but I know that my family and I decided that this was a reasonable decision for everyone, for us, for our family, and for their future and their future life. So I think that as everyone has said, this is going to take time. This is going to take education. We are not going to be able to give all the care to everyone. It is just a fact of life. The other fact of life that no one wants to talk about, but it is going to happen in this country, and I will I will bet anything on it, is there's going to be 2 levels of care, at least. There's going to be levels of care that people can afford to do what they want to do, and they're going to pay for it. And they'll have a private hospital and a private doctor, and they'll operate, and they'll do as much as they want as long as you can pay for it. And Americans don't like to discuss this, but the reality is it exists in England, it exists in France, and it exists in Canada, and it's going to exist here. We don't admit it, but it's going to exist here. And those people who want surgery well into their 90s or 100s are going to say, fine, spend $50,000, they didn't care, do it. So it is an issue for the average public that we have to discuss, and it's going to be an issue. I mean, we've heard of the expense late in life. Some people say it's 70%, 30%, 40%. It's not 70%, that's for sure. And it's probably not 10 or 20. We're not really sure what it is, but it's probably somewhere in the 25% range by most reasonable studies. And the question is that a good expenditure of our assets, or should we start focusing those expenditures more toward the younger people?
Next question. Todd, I saw your hand up.
Ask, you want me to stand up?
No. I saw your hand up. You can sit down. I can still see.
I want to ask kind of a process question. And it has to do with what has changed or not changed from the Claude Pepper years and the Pepper Commission to certain care and now to the current effort under, you can't really call it Obamacare, it doesn't sound right. The current effort under the administration. Many of the facts and figures that you have quoted are right on target, and they have been for many years. We knew about the aging baby boomer population, and we knew what kinds of demands they were going to place on the system. So the process question is this: what has or has not changed over this period? And is there anything different today? In other words, will change actually begin through this current effort or not? To me, the process hasn't changed that much. I don't know, is it just a matter of part of the process, voices getting louder, or what?
Anyone?
Well, one thought that comes to mind, I think the political will for change has changed from the 90s and even the Clinton years. I mean, if this election was a mandate to some extent about health care, and the president chose to respond to it as quickly as he did with his plan, then that is an indication that it was a front and center issue at a larger degree than maybe before. And I think the aging of the population might now finally be resonating as a concern that people want to address through modifications and changes in healthcare. In the Claude Pepper years in 1990, it was just sort of, well, they're getting older and we got to get ready, but didn't quite pan out. Another thing that's missing is Claude Pepper. Man could move mountains through his own will to just simply recognize the fact that he was the most authentic advocate for a cause that ever lived, frankly, is my judgment, because he was speaking as an older person on behalf of older people. But things are more complicated, but people are better educated to some extent now than they were maybe 15, 20 years ago. So there's a mixture of things. I'm not sure there's any one set answer to it, but of course, obviously, the outcome of what happens in healthcare reform will determine whether or not change has really occurred or not.
Ron?
Well, I was thinking about it. That's why I asked Bob to talk. I was involved with the Hillary program. My wife and I were deeply involved with that administration for many years, and have huge respect for her and for the president. the mistake that I think they made, and it's always smart, it's always easy to look back and say that, but I think the mistake that people tend to make early when you try to do something is to not engage people early enough and for a long enough period of time to get their buy-in. You basically have, it's interesting. You have a very similar thing now. I mean, let's look at the reality. The doctor group goes for a meeting at the White House. The insurance companies go, the pharmacy companies, the whatever. And then we hear that, and there's a big press conference, and everybody says, oh, that's great, they're going to save $80 billion, they're going to save $20 billion, and everybody goes home. The reality with healthcare, it is so enormously complicated that you need to engage the people existing in it for periods of time. You can't just do something. It is a process. And I think, frankly, we're doing the same thing that we did I was head of quality, and, how do you get quality something back, during, and what I did is to try to engage people over a long period of time and get their input. People want to do something different. There isn't anyone in this country who doesn't realize we need to do something, but everyone involved in the current system wants to be part of it and feel that they have a role in it and that they can make a difference. And I think until we really seriously engage all aspects of it over a period of time, that's not going to be over 3 weeks or 4 months. That's going to be a long period of time. I think we're going to have people fighting us, and I think everyone understands. I mean, when you talk privately to the people in the field, everyone understands that. I'll just give you one story. I remember going to the White House on the East Wing when we had everyone together, and we were there to talk about health reform. And, being old, my experience is you go with a yellow pad and you sit back and you listen. And what obviously we did was we spoke for 3 hours. And then when we were walking out, I'm kind of walking, listening, and everyone said, I'm not part of this thing. I'm not going to do anything here. And you could hear it. You could hear all the surgery groups and everyone. And so, I mean, there's differences, but there's a lot that is the same. And I think until we get a long process of getting certain things done, certain things ought to be done. You could do electronic medical. I mean, the government could do that in a minute, make sure that everybody has, when Aetna, United, Cigna, and everybody who takes government money, at least they should have a common database for all the money that the government spends. If the government is paying for it, they ought to demand that data, because they don't know. Everyone's got their own database, and United's not going to share it, and Cigna's not going to share it, and Blue Cross of Wisconsin's not going to share it, and so forth. And the government needs to just say, we are going to do this. Some people are not going to be happy with it, but that will be a start.
One more quick point.
Certainly.
One thing that has, and Ron reminded me of it, and that is, even though it's still early and undecided, I think some of the industry overtures that have been made, that have been extracted from President Obama through his meetings, are different from what we have.
And help.
That Medicare, that Part D donut hole infusion of funds from the drug company, I think is huge for a lot of older people in this country. And if that can stand up through the scrutiny of health care reform, you would have made a significant reform that maybe wasn't possible the last time around, just because you engaged them.
Marty, do you have anything to add?
Washington policymaking is not my knowledge base. At the hospital level, change has to occur. I think we do have a crisis. And I think at the patient level, because the emergency rooms are essentially the insurer of last resort, and they're being overwhelmed, and the hospitals are being overwhelmed. And so the states are being overwhelmed. Medicaid is breaking the back of so many states, and we see it now in the recession because they have no maneuverability at the state level and the federal level. So I think all these things are compounding, okay, at a moment in time that some change has to occur. And I don't, what it will be, I'm not sure, but the system cannot go another 5 or 10 years without some changing in the treatment of care and the funding of it and the efficiency of it.
David.
Yeah, I just wanted to follow on that because I was listening to the opening statements for you, and I thought they were opening statements about what middle-class, educated boomers wanted, and that essentially a third of the population isn't even in on that discussion, probably is never going to have a voice, but they're the people who are breaking the backs of the system because they aren't insured, they're losing their jobs, they're taking their pills every other day. They're doing all these things, and they want something, and they're about to, if they aren't out of a job now, they're going to be out of a job in retirement with too little income. What do they need? How is that? And that's not very far off.
Panel?
In New York, we just went through reform, in quotes, everything's reform, but it was significant. And it's a little piece, but it's important in that area, in that the state is reallocating the Medicaid funding, the same pie, okay, moving it away from the major medical centers that are getting a larger share of that pie to the hospitals, which are really dealing with the urban poor, the people you're talking about. That was not easy to do, okay, and all of the hospital establishment of the big hospitals opposed it. Hospitals like us, okay, supported it. It's a step, and what is the money supposed to do? It's supposed to support the treatment of Medicaid, but they've also done another change, increase the ambulatory reimbursement, because in New York, okay, the reimbursement for an ambulatory patient was just not affordable. The doctors would not take Medicaid patients, okay, so they came into the ambulatory centers of the various hospitals. Many of them are academic, many of them are community hospitals. But okay, you could not make money, okay, on an ambulatory center. So the reform in New York is to increase the ambulatory reimbursement. May not sound dramatic, but it's beginning to give it a financial incentive. So these people do not rush into the emergency room. They can get preventive care. They can get care in an ambulatory center. So one of these progressive steps is to have more ambulatory centers where the people can go to and make it affordable to manage and run these centers. It's not a revolutionary thing, but it's an incremental step, but an important one.
And the same thing with community health centers.
It's community health centers.
I mean, that's the investment that's been made in community health centers over the past number of years by all the last two administrations, frankly. I think it's the signals that there's a gap that needs to be filled for that precise people you're talking about. The other point I'd make is that your question raises the very issue, which I think is fundamental to this whole debate, which is healthcare reform is an economic issue. We've got to put those things together. It can't be viewed as a separate conversation. And, you ought to be putting both things out on the table more often.
The problem in having a smart guy ask a question is when I was preparing, I was doing my work on this, I thought the exact same thing. So at the bottom, I had obesity, diabetes, not getting immunizations, all the care thing. These are massively hard issues. When we, I know David and have great respect for him. I'm not surprised you asked that. Because when we do talk about boomers, we tend to talk about the upper middle class. I mean, and it's easier and it's more fun. But the reality is that the out-of-work, lower-class person, lower economic person is a huge issue. But with that, I just have to tell you one thing that drives me crazy that Martin just mentioned about New York is an example. We are very involved with Medicaid. Now, for you, those of you who don't know what Medicaid is, just 1 minute. Medicaid is really insurance for the poor, which is a combination of state and federal funds, which go to the state. The state then distributes those funds based on economic eligibility. The state, not the federal government, forms the eligibility criteria. And one of the things that people like myself have done is that we have basically eliminated waste in Medicaid. So anywhere where we work, we basically make sure that if the person is a Medicaid person, that they really exist, that you visit them and you make sure that they have a name, an address, a phone number, and a social security number. And if somebody's going to treat them, you make sure that that ambulatory clinic really exists. And it's not just a storefront, or that somebody, or if it's a camp, or I'm a psychiatrist, so we have treatment programs, which frankly, places that we were with, that states that we deal with, many states, we're paying $500, $700, $800 a day for something. When you go visit them, there's nobody there. There's nothing there. So we by and I keep saying this, organization, systems, and management, you eliminate waste. New York State just came out with it the other day, and it's been driving me crazy. They pay millions and billions of dollars to people who don't exist. The person doesn't exist, and the treatment program doesn't exist. And they're created because it's a massive program. And we, you can just imagine how much money we would save if we just knew that the people we treated were real people, and the places that they were treated are authentic places.
Mm-hmm. Lady in the back.
I'd like to go back to the question and issues we're here for, which is what do boomers want? And by the way, I'm one of those in denial, and I think we should change geriatric medicine to the second half of our lives medicine. But in the last year and a half, 2 years here, we have been interviewing women, so I've got to keep men out of this, across the United States in one particular subject. And what we found, and it's pretty much all the boomer generation, and they were all walks of life, but we heard the same thing over and over and over again. You can read books, you can go on the internet, you can go to a doctor, and you'll go to 3 doctors, and you'll get 3 answers. They don't know who to trust. It seemed to me that if the healthcare system maybe made doctors have more education, so they're a little bit more on the same page, you would have less people going around the country trying to get their answers from different doctors. We even talked to some doctors who got their information by reading headlines in the newspaper. And so they went along with the studies that came in the newspaper and never checked the data. This is, to me, where are we going? If we're not going to control our doctors so that our patients can't get the right information, that is one thing we heard. The second thing that we heard over and over again was that we go in to see a doctor, they tell us the insurance companies only pay for 15 minutes of our time. They have 15 minutes to get out everything that's wrong with it. The doctors don't listen. They don't have time to listen. You're in and out, so you can get paid by the insurance plans. So from the women's point of view and the issues of the second half of their lives, the doctors don't have time to listen. They probably weren't trained on some of the issues, and they don't want to talk about it. So how do we overcome this part in the system of what boomers want?
Change your doctor.
Bob, do you have something to add?
I mean, it's a real issue. I mean, it's you can't, gloss over it. I mean, I'm more inclined to think about the older woman who is, dismissed out of hand by a doctor because you're just getting old, or it's just some reference that sort of dismisses the core issue of why that person might be there. I mean, communication is a critical, overlooked issue in healthcare reform. How to do better communication. But it has to do with education of the physician. It has to do with education of the patient as well. I mean, but I think the place where you might have a chance to examine a policy change might be in whether or not they finally get around to revising the Medicare reimbursement arrangement for geriatric medicine, geriatric care, so they can spend more time and provide better answers to that rapidly growing segment of the population. But we concede your point. It's hard to disagree with it.
I don't think you can change individual physicians or other people after a certain age. They know what they know. They've been trained in a way. So I think some of it comes with generational change, starting at the medical schools, et cetera. But I think particularly with regard to the aging of the population, the new boomers, More and more, I believe, you need team approaches to it so that there's a group of educated people. It's not just one person. It's a group of doctors, nurses, social workers, et cetera, working in a team. That will not fit individual younger people. They're not going to want to go so much to the team, but it certainly works pretty well with older people as they're aging. So I don't think there's a policy decision that can make it. There's good medicine and there's bad medicine. There's good doctors and there's poor doctors. But I think as we go, more and more, you see more and more a hospitalist setting. So in the hospitalist area, I think you're seeing more control, that the hospitals can take more responsibility for the quality of what they do. But the time pressures in the doctors, it's real, and I don't see that going away.
One thing to watch in the healthcare debate, just as we go forward, is the whole where does the medical home concept go? Okay, does it go from being a demonstration and a pilot of progress? Did it actually get something where where you put a team together, a multidisciplinary team on behalf of providing care and care coordination? That's got great potential to address at least some of the issues you're talking about.
We have time for just two more questions, and Ron has a
I'll
comment.
give you a copy of an article which I think you'll enjoy reading, and you can copy it. On it's called DIY doctors, do-it-yourself doctors. I think you'll enjoy.
Lady in the back in the yellow.
Yes. Okay, thank you. I'd like to connect with what you're talking about, and also Martin, what you had brought up about that poignant contradiction in finding that with a rapid response team you are able to actually increase the level of care and the effects of that, and that at the same time the reimbursement rate, the economy has been not as desirable. And I wanted to talk also about I actually do want to ask a question, not just talk. I work for an institute that is trying to track and promote local leverage changes that have great effects in the sense of incremental, trying to see if we do this, et cetera. And the core thing that I would ask the general, particularly Martin, is what hasn't been brought up is, or I haven't heard it, and I admit I came late, is to what degree we need to scrutinize the regulatory effects of business on what might be really desirable healthcare changes. Meaning instead of a little bit, I hear a lot of trashing of the government and a lot of, healthcare needs to reimburse us in order to make this pay. To what degree does business need to re-examine its aims and motivations? And just briefly, here's the scenario. Exactly about time, the rapid response idea has been something we've been tracking. It's simply called in permaculture time edges, where there's certain times where you can create an interaction between physician and patient that has huge leverage effects, both economically. Ideal medical practice, West Coast, they find that if initial patient interviews are 2 to 4 hours long, initial patient interviews, that this has leverage effect is that later the patient has asked all the questions, has understood the role of the physician has mentioned she has 2 kids at home, even if that physician has given the cell phone number 24/7 to call me, that patient tends, after that initial time edge, that first interaction, not to do so many follow-ups, certainly not to go to the emergency room. So we've been tracking the fact, also Gesundheit Institute insists on hearty, hefty initial patient interviews. Business-wise, with reimbursement rates for those initial patients, reimbursement rates are often for diagnoses and treatments, it doesn't pay. So it makes us turn around and look leverage-wise that it may be that some of the incentives financially need to be re-examined. And business itself needs to be interrogated for its negative effects on what would be otherwise good changes in healthcare. Martin.
Okay, I'll be quick because when you have the emergency room today, not tomorrow hopefully, is still the main entrance point to most hospitals in urban areas. We have 100,000 going. We started maybe 5 years ago. We had 65,000, 100,000 visits a year. You can't have these interviews that you're talking about.
No.
Now, there are a lot of things. You call it business. I think it's mission. And the mission really is to be efficient, to do it right. And I think it depends that you have to create a culture in the individual institution and find where you can make the inroads. There are a lot of less expensive personnel you can use to accomplish that interview that you're talking about. We have a large core of patient representatives, maybe 40 or 50 to deal with this 100,000, and they deal with the families and get an awful lot of information, okay, not at the doctor level if they're trained. So that each institution has to determine they're going to do the best they can with their resources. I worry about reimbursement, frankly. Do the job first, do it well, and then we go to the government and say, okay, what our problems are. And you know what I found? They've helped us. Because if they don't help us and we fail, they have a bigger problem than we have. So we're in line with what you say, but it's going to be done in little things. But it's more than a business. It is different than any other institution. I'm talking about the not-for-profit, and I believe the for-profits that are really have to work the same way. But the complicated, difficult work are being done in urban not-for-profit centers, and it's incremental, as Ron said. But you have to focus on the mission. And if you focus on the mission, somehow the reimbursement will follow.
I have one more question, and it's the gentleman in the back.
I would just maybe close with you asked what boomers want. We're a large nonprofit. I think we're 23rd or 24th in the country, so we're constantly trying to figure out serving seniors where we want to be in the next 5 and 10, because that's about as far as you can look, maybe 3. But I would leave everybody with the thought that I think the boomers are going to want a couple of things. They're going to want, one, they're going to want quality. They're going to want the definition of what is quality. They want to see those benchmarks. And they want customer service. They're not going to be like the silent generation. They're going to want customer service, and more like the service you get at the Ritz. That's what we're going to expect, at least for the portion that we're talking about, not the non-sexy bottom third. And I think you're going to need to have whatever you deliver to them is going to have a sense of purpose. Ultimately, a sense of purpose every day for them to get up and do what they do, or to be involved with each other. I think if we can do that, we'll be successful.
That's an excellent statement to, in fact, close on. I would say. I would like to close by thanking our panelists for being so candid and so very thorough. I've not heard in all of the days that we've been here the rationing word before, the cost equals care, containment, the 2 levels of care, and medical homes, which is kind of interesting, and the IT. So thank you for bringing up those issues, and thank you for coming out so early.